Hello everyone, today's lesson is about pertussis. Pertussis is a highly contagious respiratory tract infection that is easily preventable by vaccine. It was named by synonyms first, and it's used to mean intense cough. It is preferable to this pertussis, or this word is preferable to whooping cough because most infected individuals do not whoop. Bordetella pertussis is the sole cause of epidemic pertussis and the usual cause of sporadic pertussis. Bordetella parapertussis is an occasional cause of sporadic pertussis. When we see the epidemiology, 60 million cases of pertussis each year worldwide happens, and it results in more than 500,000 deaths per year. Widespread use of pertussis vaccine leads to a decline in pertussis cases by more than 99%. And pertussis is extremely contagious, with attack rate as high as 100% in a susceptible individual exposed to aerosol droplet at close range. And in households, the rate of subclinical infection is as high as 80% in fully immunized or in previously infected individual. And neither natural disease nor vaccination provides complete or lifelong immunity against reinfection or disease. Protection against typical disease begins to 3 to 5 years after vaccination, and it is unmeasurable after 12 years. When we see the pathogenesis, coughing adolescent and adults usually not recognized as having pertussis currently are the major reservoir for Bordetella pertussis, and they are the usual source for index case in infants and children. And Bordetella organisms are tiny, fastidious, gram-negative coccobacilli that only colonize ciliated epithelium. And the exact mechanism of this symptomatology remains unknown. Only Bordetella pertussis express pertussis toxin, and this is thought to be the major virulence protein. Even though it is not the only, it is thought to be the major virulence protein. Pertussis toxin causes lymphocytosis immediately in experimental animal by rerouting lymphocyte to remain in the circulating. In addition to pertussis toxin, there are some other virulence proteins from this. After aerosol occlusion, filamentous hemagglutinin and the pertactin protein are important for attachment to ciliated respiratory epithelial cells. And also tracheal cytotoxin and adenylate cyclase, and with pertussis toxin, they appear to inhibit clearance of the organism. And tracheal cytotoxin, dermonecrotic factor, and adenylate cyclase are predominantly responsible for the local epithelial damage that produce respiratory symptoms and facilitate absorption of pertussis toxin. When we see the clinical manifestation, there are 3 stages of illness: catarrhal, paroxysmal, and the convalescent stage. And the catarrhal stage it ranges from 1 to 2 weeks, and it is characterized by having incubation period which ranges from 3 to 12 days with non-distinctive symptoms of congestion and rhinorrhea, and low-grade fever, sneezing, lacrimation, and the conjunctival sufficiency is common. And the paroxysmal stage, which ranges from 2 to 6 weeks, is characterized by the cough which begins as a dry, intermittent, irritative hug, and it evolves into the inexorable paroxysm that are the hallmark of pertussis. Machine gun burst of uninterrupted cough, and chin and the chest held forward, tongue protruding maximally, eyes bulging and watering, face purple, until coughing cases, and a loud whoop follows as inspired air transverses the still partially closed airway. And the post-tussive MS is common, and exhaustion is universal. At the peak of the paroxysmal stage, patients may have more than 1 episode hourly, and during convalescence stage, which is more than 2 weeks, the number, severity, and the duration of the episodes decrease. Infants less than 3 months of age do not display this classic stage, and the catarrhal phases lasts only a few days, or it is unnoticed in those less than 3 months. And the paroxysmal stage is characterized by choke, gasp, gag, and the flail extremities with face reddened. Cough, which is most of the time associated with expiratory gland, may not be prominent. And whoop infrequently occurs in infants less than 3 months of age who at the end of the paroxysm lack stature or muscular strength to create a sudden negative intrathoracic pressure. So since they can't create a sudden negative intrathoracic pressure due to lack of strong muscle, they don't whoop at the end of the cough. And cyanosis can follow a coughing paroxysm, and apnea can occur without a cough. And apnea might be the only symptoms in just less than 3 months. And the paroxysmal and the convalescent stage in young infants are too long compared to the older one. And paradoxically, in infantis, cough and the whooping may become louder and more classic in convalescent phase. Immunized children have a foreshortening of all stages of pertussis, and findings on physical examination generally are, most of them, they are uninformative. And signs of lower respiratory tract disease are absent, and conjunctival hemorrhage and the petechiae on the upper body are common. When we see the diagnosis, most of the time diagnosis of pertussis is clinical. Cough illness which ranges in duration more than 14 days with at least one associated symptoms of either paroxysm or whoop or having post-tussive vomiting has a sensitivity of 81% and a specificity of 58% for culture confirmation. Pertussis should be suspected in older children whose cough illness is escalating at 7 to 10 days and whose coughing episodes are not continuous. And pertussis should be suspected in infantis less than 3 months of age with apnea, cyanosis, or acute life-threatening. When we see the investigation, leukocytosis, which might range up to 100,000 due to the absolute lymphocytosis, is a characteristic in the catarrhal stage because the pertussis toxin causes rerouting of lymphocyte to the vascular lumen. And severe course and the days are correlated with extreme leukocytosis and the thrombocytosis. And the chest X-ray is only mildly abnormal, showing perihilar infiltrate or edema, sometimes with a butterfly appearance and a variable atelectasis. And also pneumothorax, pneumomediastinum, and air in a soft tissue can be seen occasionally because of the complications. And also parenchymal consolidation presence suggests secondary bacterial infection. Otherwise, parenchymal consolidation is not due to pertussis. Macrolides are preferred agents when we see the treatment, which have similar efficacy in vitro, and a 7 to 10-fold relative risk for infantile hypertrophic pyloric stenosis or IHPS has been reported in neonates treated with orally administered erythromycin. And azithromycin is the preferred agent for use in neonates. When we see the prevention, isolation is very important. Isolation until macrolide prophylaxis has been taken for 5 days. And a macrolide agent should be given promptly to all household contacts and other close contacts because it is so contagious. When we see the prevention, the most important thing is vaccination. Clinical efficacy against severe pertussis defined as paroxysmal cough more than 21 days is 80 to 85%. So vaccination is very important. When we see the complication of pertussis can be due to direct bacterial infection, or it can be due to superimposed infection, or it might be due to the severe paroxysmal cough. Severe paroxysmal cough can cause secondary complications. So apnea, secondary bacterial infections such as otitis media and pneumonia can occur, and increased intrathoracic and intra-abdominal pressure during coughing can result in conjunctival hemorrhage, petechiae in the upper body, epistaxis, CNS and retinal hemorrhage, pneumothorax, subcutaneous emphysema, umbilical and inguinal hernia, all can happen. Thank you for listening, and also thank you for subscribing this channel.